Okay, so once again, welcome everyone to the session. It's a great pleasure having you today and hosting us for this wonderful event. I'm sure most of us have really anticipated for this session, and I hope that you managed to read through some of the resources that were shared on infectious diseases, just to as a preparation for the session. So, I'd love to welcome. In particular, our guest speaker. Thank you so much for making it today to this session. And just to introduce the session for today, which is Introduction to Infectious Diseases. And then we'll have a general introduction about AMR, just trickling down from infectious diseases, because we know drug-resistant infections are mostly infectious. So, Dr. Yara, just to introduce her, she's a consultant with the World Health Organization, and she's also an infectious disease clinical pharmacist, as well as an antimicrobial stewardship clinical pharmacist at International Medical Center Hospital, which is in Egypt. I've had the privilege of engaging with Dr. Yara, both virtually and physically. She has really been supportive in terms of student empowerment and the empowerment of early career professionals in to becoming active AMR champions within our African continent. And she really does a lot. And I think we'll also invite her for another session to just share more about her work. And she has really done a lot in terms of, raising up a young generation that is sensitive to, the challenges that are facing our continent in terms of AMR. So without further ado, I'd love to introduce you, Dr. Yara. Thank you so much for your continued support and for always being available when we request you to support us. Thank you so much. It's such a great pleasure. Over to you. Thank you.
Hello, Daniel. Thank you so much for the introduction, and it's always a pleasure to engage. Thank you all for being here, and thank you for the invitation as well. I can see like huge specialities and different people joining from different specialities. So this is really interesting. So without further ado, let me share my presentation. Okay, yeah. So again, I'm really very excited to be joining today. This is just, let me say, it's setting the scene. It's just discussing some of the very basic things regarding to communicable diseases and infectious diseases. So this is the outline of what we're going to be discussing today. We'll be going through what is epidemiology, what does epidemiology means. We face this terminology a lot. What does this mean? What's the difference between the communicable diseases and infectious diseases? What's the chain of infection and the mode of transmission? And then we'll be giving like a brief overview about what is AMR, what's the magnitude, the current magnitude of the problem, how does this connected by one way or another regarding the antimicrobial utilization, and how we can solve this, how all of you can be part of facing or curbing the AMR current crisis that we're dealing with. So let me first start with a very brief definition of what is epidemiology. So it's basically it's the scientific study, it's the data-driven study of the distribution and determinants of health-related issues. So in distribution, I mean, it goes really into the frequency, the patterns, the causes, and the risk factors. It is concerned with all the health-related states and events, not only diseases, and it is concerned with specific population, which is under the study. And the most important thing about epidemiology, that it's not only concerned with studying, but also the application of this study on how to control different and various health-related problems. So epidemiology, we have two types of epidemiology. This can be, we have the descriptive epidemiology and the analytical epidemiology. So in the descriptive epidemiology, we are more concerned with the when, the where, the who, and the what of the condition under study. We are more concerned with the person, when we say the people, place, and time. This is our concern. This is what we're looking for. On the other side, in the analytical epidemiology, you are more concerned of the cause. We call it the triangle. It's the agent, the host, the environment as well. So as you can see here, we have the host, the agent, and the environment. In the host, we have the demographic characteristics. So the age, the race, the gender, the educational status, the marital status, all of what of concern with the host. We are also concerned with the agent under study, which is it can be the biological agent, the physical, the chemical, the social agent that we are studying, and then we have the environment. So per se, we want to be studying this certain infectious problem on the certain population in the ICU. So we want to be working on ICU people in the intensive care unit. We want to be working with people in the surgical wards, hospitalized patients in the community. So this is the environment that we are dealing with. And then one of the very other famous terminologies that you can hear and come across while reading, it's the communicable versus the non-communicable diseases. So epidemiology, it strikes most people that epidemiology also deals with non-communicable diseases. So epidemiology is not only dealing with communicable, but also non-communicable, like oncology, cardiovascular diseases, diabetes, obesity, other issues. But what of concern for us today, what we are going to be dealing with today, is the communicable diseases. And let us start at first with discussing what is communicable diseases. What do we study in communicable diseases? What do we find? So communicable diseases is basically, it's the illness due to a specific infectious agent. It can be transmitted, and this is the most important part, that it can be directly or indirectly transmitted, but it has to be transmitted from either man to man, animal to man, or even animal to animal, or from the environment through air, water to the man. So at the end, it has to be transmitted one way or another. Why do we need to study communicable diseases? It really helps us to understand more and grasp more about the changes of the pattern of infectious diseases. It helps us in the discovery of new infections. Like, I believe you're very aware of what we've been dealing with in the past couple of years, the COVID-19 and currently the monkeypox. So it really helps us to understand and gain knowledge and insights about this. It also is very common to help us the studying of some chronic diseases that have an infective origin as well. This brings us to the next definition that we're dealing with, which is, what is an infection? So infection as a terminology, it is more concerned with the entry and the development of a multiplication of an infectious agent in the body of the man or an animal. Infection itself does not always cause illness. So sometimes there is the colonization. So it's microorganisms simply living on our body. So we have the staph epidermidis that's lying on our skin. We have some microorganism that it is living in our genital tract, some organisms living in the GIT tract. So these are organisms colonizing us, okay? So it doesn't necessarily mean that they would cause infection. They are living with us. And then we have the subclinical infection. So it's infection with no apparent symptoms. And this is per se like the polio. And sometimes there are latent infection, and latent infection, which is where the organism remains inactive in the body, like the TB or the herpes simplex. And sometimes the infection does have manifestations and have clinical symptoms, and sometimes it's even a systematic infection, like dealing with people with sepsis and septic shock. So again, back to what we've been saying, that the infectious disease models, it encloses having the host, the person with the problem, the pathogen itself, the environment where the person is staying. So the person is in the community, he's in the hospital. This is what we call the infectious disease model. So this comes to and raises a very important question, which is that what's the difference between the infectious disease and the communicable disease? And are all infectious diseases communicable? This is a very important thing. So infectious diseases are both communicable diseases and diseases caused by microorganisms that are not communicable. Let's give an example here. So per se, tetanus is an infectious disease, but it does not spread. So we cannot consider it as a communicable disease, yet it is an infectious disease. And this is very important, again, to understand the difference between both. So as you can see here, you can find the impact of infectious diseases also on children. There is a very high burden on the impact of infectious diseases. It's one of the really, as you can see here, sepsis and meningitis. It's one of the very normal and very causative organisms for death for children under the age of 5, according to the WHO report on 2016. So what is the chain of infection? How does infection happen? How can we stop this? How can we include all the options that is concerned with infection? So for the chain of infection to be complete, we need to have a host. This can be an elderly patient, an infant, as we've been saying now, discussing the mortality on children under 5 per se, immunocompromised, immunocompetent. So it can be anyone. And then we have the pathogen, which can be a bacteria, a virus, a fungi, or even a parasite. Then we have the reservoir, and we'll be talking about this in a couple of minutes. And then we have our portal of entry, which can be through the mouth, the nose, the eyes, or even cuts in the skin. And then we have the portal of exit, which can be the feces, other bodily secretions. And we have the mode of transmission that we will be also talking about in a couple of minutes. So for the reservoir, we have the human reservoir, we have the animal reservoir, and we have the non-living reservoir. So for the human reservoir, this is what we call the carrier. This is for per se, like the sexually transmitted diseases, the respiratory pathogens, and even carriers have different types. So we have the convalescent carriers, the chronic carriers, and so on. And I don't want to be going through medical details because I was acknowledged that there are different, again, specialties attending. So again, the importance of this is just laying out some definitions, some core definitions, and some core information. We also have the animal reservoir, and this is called the zoonotic diseases. Per se, we have the brucellosis, the anthrax, and other infectious diseases where the reservoir is the animal. And sometimes we even have the non-living reservoir, which is the environment. This can be plant, can be soil, or can be even water. A very famous thing, which is the Legionella infection, which can be it typically causes the pneumonia. It's the very most common source of infection is a contaminant of the water supply. So the reservoir here is a non-living reservoir. It's the environment. It's in the water. So this is very another common infection, which is where the reservoir is an environment. Regarding the mode of transmission, we have different modes of transmission, and we can classify them to two major things. So we have the direct transmission, and we do have the indirect transmission. So for the direct transmission, we have the direct contact, we have the droplet infection, we have contacts with the soil, and then inoculation. For the indirect transmission, we actually have the vehicle-borne. The vehicle-borne means it's a non-living thing. This can happen through food, through water, and something like this. For the vector-borne, which is the fly, it's the mosquito, the fly, we have two different pathways. This can be a mechanical pathway, and this can be a biological pathway. So basically for the mechanical pathway, simply you pick, the fly picks the infection outside the body. So the pathogen here, it never enters the body of the fly. It doesn't enter, it's on a mechanical pathway. But for the biological, the vectors harbors the pathogens within their own body. So that's the difference between saying a mechanical and a biological vector-borne. And then we have the airborne, and another example is again having the formite borne. So these are the two major, again, modes of transmission of the infection. So I really love this picture because it's I'm very sorry. There was a problem with the internet connection. I'm so sorry about this.
Okay. Yeah.
Yeah. Okay. So this is really one of the very elaborative diagram regarding this point. So as you can see here, we have the infected person, and then we have the susceptible host. For the airborne infection, it is sustained in the air. So we have this droplet nuclei, and then the susceptible host, has to take it via inhalation. Okay. But for the droplet, which is the direct pathway of the mode of transmission, it has to travel directly to the mucosal surface. And then we have the contact, which is the direct contact per se, or indirect contact, where it is depositioned on the contaminated surface, and then the susceptible host have it via contact or via contact behavior. So this is how there are different modes of transmission. So let me ask this question. So do we need to have all 6 links in order to say that we have the chain of infection? So the answer is yes. You must have them all. You must have the host, you must have the pathogen, the portal of entry, portal of exit, the reservoir, the mode of transmission. You have to have all the links in order to have this complete cycle with it. So if we want to break this cycle, we really need to be working on all links that we...
It's like squadron, but
Ebra, can you please mute?
Okay.
Hello. Sorry,
Yeah.
Dr. Yara, for that interruption.
No problem. Yeah. So again, I was just saying that, okay, so we have the chain already of infection. We have all the 6 parts of it. We have the bits of it. So if we want to break this chain, to break the best. So there are different literature and so on about this, but all of the people say that it's best to break from the mode of transmission. This is the best way you can break the cycle of infection. But again, it's very important that you work on all bits of it. So yes, if you want to do it best, it's better to break at the mode of transmission, but then you have to work on all bits of it. So you have to kill the pathogens. That's where we give the antimicrobials, where we work on the pathogen bits of the thing. If we want to prevent contact, we need to be working on the contact isolation precaution. And for people already practicing and working in hospitals, we have the contact isolation, we have the airborne precautions, and there are different precautions according to the type of the infection, and the needed PPEs to be based on the different type of infection. Is this a contact isolation? Is this a droplet? Is this an airborne? So each has its own different PPEs. And then you have to prevent the escape of the pathogen. So you have to be working on the portal of exit. So the pathogen can't get out of its host, hence the disease will not be able to spread. And this is, again, working with the basics, the things that we've been talking a lot about in the COVID pandemic. So covering your mouth when sneezing, the wearing a band-aid to cover the wound, all of this, of course, helps a lot. And the most important thing, which is preventing the transmission. So just preventing the pathogen to travel, okay? So this can happen according, basically just controlling the infected animals, controlling the insects, ensuring proper treatment of sewage, chlorinating the water. There are different ways to prevent the transmission. And here comes the part of the infection control team maybe working in hospitals. And then it's very important to be working on the host themselves. So basically exercising, eating well, and then the very basic thing, which is the immunization, the vaccination, which is really very important. So you have vaccination for children, you have vaccination for adults, and of course for the neonates, there's the EPI-8. These are the important vaccination that needs to be administered for newborn kids and so on. So let's give an example here for working per se with the COVID. So as you can see here, if we want to, we're working on the whole chain. So the infectious agent, the susceptible host, the reservoir, the portal of exit, the portal of entry, and even the mode of transmission. So you stop the source, you block the portal of exit simply by doing the coughing etiquette, by using your hand, interrupting the mode of transmission by properly washing your hands, the hand hygiene, the portal of entry, wearing your own masks, and increasing the host defense, which is the vaccination. So this is a very simple elaboration on how you should be doing and how you should be breaking the chain of transmission. So up to now, what we've discussed the epidemiology. What is the epidemiology? What is epidemiology concerned with? And then we've discussed the communicable diseases and what's infection, what is the chain of infection, and all bits of it. Now we need to be just raising this very important thing, that we have different types of infection, one which is called the nosocomial, healthcare associated, or hospital acquired infections, and all are the same terminology. And then we have the community acquired infections. So nosocomial infections are basically, and very simple, these are the infections that take place inside the hospitals, while community infections are the infections that take place outside the hospitals in the community setting. And of course, and I believe this is very clear, that we are really having a huge problem with the nosocomial infection bits of it, where the microorganisms are strong, where we have the superbugs, we have all of these issues that we will be discussing in the couple of slides, upcoming slides. So this is the Center of Disease Dynamics, Economics, and Policy. And as you can see here, based on this study, the 5 most common hospital-acquired infection, or as we were just saying, nosocomial infections, they cost just only the US $9.8 billion USDs annually. And the cost per case, the most important issues, or the 5 most important issues. Number 1 comes the central line associated bloodstream infections. And for those people not working in the hospitals, the central line, it is a line commonly used in patients staying in the hospitals, where they can deliver the medications for the patient, the electrolytes, and so on. So using a central line, you can also use it for patients who are on hemodialysis in the hospitals. It's also the portacath used for patients having chemotherapy, again, in the hospital. So all of these are under the central line. And these are really associated with high burden of bloodstream infection. And this is the top most and high cost for infections and hospital-acquired infections, even in the US. Number 2 comes the ventilator-associated pneumonia. And people, again, so for people not working in the hospital, so the ventilator, it's a machine synchronizing the breathing for the people who cannot do normal breathing. We normally use it in the ICUs. And people on ventilator, they get this pneumonia, they get this lower respiratory tract infection called pneumonia. And this is the second, again, cost per case in the US. And then the surgical site infections, and the surgical site infections are infections that people do get after the surgeries. Of course, we face this issue a lot in complex kinds of surgeries, like laminectomies and orthopedic surgeries. And part and huge toll of this whole thing relies on both the infection prevention and control and getting the appropriate antibiotic preoperatively. And then we have the C. diff, or the Clostridium difficile, and the Clostridium difficile. It's one of the high tolls and high burden of infections in the US, and it's really attributed with the misuse and overuse of antibiotics. And there are really highly resistant Clostridium or C. diff infections in the US, and it's a really huge burden for them. Maybe in Egypt, where I work, it's not a huge problem for us, but it's in the US, they are really facing a huge problem with this. And at last, we have the catheter-associated UTIs, or urinary tract infections, again, which is called the CAUTI. It's a huge problem, again, for people staying in the ICUs where they have the catheter. And it's a huge problem, and people do have complicated catheter-associated urinary tract infections for having the catheter for long durations. And again, all of these are types of, and the most common types of, hospital-acquired infections. So why hospital-acquired infections is a problem? Why is it of concern? Why are we talking about? Why are we giving it this importance? So basically, this is somehow related with the other topic that we are discussing today, which is about the antimicrobial resistance. So antimicrobial resistance, this terminology that is really very famous nowadays and trending, and all people are talking about how this is of importance and how this is related to of what we're discussing right now. So antimicrobial resistance is basically the resistance of the microorganism to the antimicrobial drug that was originally effective for treatment of infections caused by it. Antimicrobial resistance is actually a very broad term. Most people use the terminology of antibiotic resistance, but antibiotic resistance is only a bit of the problem. So antimicrobial resistance encompasses the whole microbiome. So it encompasses also the viruses, the fungi, and parasites. Because the terminology of antimicrobials itself, it encompasses the antibiotics, the antivirals, the antifungals, and the antiparasitic drugs. So again, most concern is going through with the antibiotics, but let me say this, that we really are now facing a huge problem with the antifungals as well. So we have these like Candida species that are resistant to azoles, which is the first line for the management of the fungal infection. Not even this, but also the last resort for the management of the fungal infections, which is a group of antifungals called the echinocandins. These even are now resistant. We have one of the Candida infections, it's called the Candida auris, which is the CDC, it urges the reporting of the Candida auris. Now it's highly resistant. It is resistant to azoles as well as echinocandins as well. So again, so it is an antimicrobial resistance issue. Most people, yes, are concerned with the problem with using antibiotics, but believe me, we are really having a problem even with antivirals and antiparasitic and antifungal medications. So let's think about this a little bit. Would you think that antibiotic or antimicrobial resistance, is it a natural phenomenon? Is it an acquired phenomenon? Well, this is really something that we need to be thinking about. So the evolution of resistant strains itself, it is a natural phenomenon. It occurs when simply microorganisms, they do replicate themselves, or when the resistant traits are exchanged between them. So some microorganisms, they produce antibiotic naturally. They use it for communication. It's good for them. It helps them to protect themselves against the action of antibiotics, and that's why they often carry a resistance mechanism. And the microorganisms environment, they do evolve over time, and the resistant variant then can be selected and can be transmitted from different species. So part of the problem, it's a natural phenomenon. That's why we will never eliminate antimicrobial resistance. We can never shut it down completely. What we can do, and what all of you are part of this, and what all of you can contribute in different specialties. I've been reading in the chat, different people in pharmacy, med, lab, and everywhere. You have a part, you have a role, you have a huge role in this issue. So we can curb antimicrobial resistance. We will never end it, but at least we can curb it. We can slow it down, because we can see now what's happening with this. So I have adapted actually this from React. It's in the toolbox of React. It's discussing how AMR is actually transmitted. I'm sorry, apologies, because the screen is small. It cannot capture all, but I believe the presentation will be communicated with you later on, so you can have a look at it. So AMR has different ways of transmission. So basically, we eat AMR, we eat antimicrobial resistance. So 70 to 80% of what we are consuming in our poultry section, in our agriculture section, it is sprayed with antibiotics, it's fed with antibiotics. So we are basically eating AMR or antimicrobial resistance. The problem is that also in the community, the people going to community pharmacies where antibiotics are being sold over the counter, and asking the pharmacist to give them antibiotics, and they simply have this antibiotic, they simply take this antibiotic, and then it can spread from the treated people to another. And then we have the hospitals. So in the hospitals itself, all the place it's contaminated. So that's why we always say, don't go to the hospital unless you really need to be present in the hospital, because you can find bits and pieces of it everywhere, and it's contaminated. You can find it on the doorknobs, even the files of the patients themselves. So it's easily transferable between patients. And then, which is really very, very important, is the traveling. So traveling itself can help to spreading of the antimicrobial resistance. Actually, one of the highly resistant gene that we are dealing with, which is called the NDM, and the NDM stands for the New Delhi metallobeta-lactamase. It's a gene. It's present in the gram-negative microorganisms. It is really has been transmitted from the New Delhi to the US and then to the whole world, just for traveling, where people go to maybe treated in hospitals outside their countries and so on. So this really helps with the spread of antimicrobial resistance as well. So where do we stand? What's the global burden? What's the currently global burden of AMR? So this was an initial report. It was done by an economist in the UK. His name is James O'Neill. It's the AMR O'Neill report. This report did clarify. It was released in 2014 and did say that by 2050, 10 million people are going to die, and this is going to be attributed to AMR. And the costing to the world economy will be 100 trillion USDs. That was the initial insights about the problem. So in Africa per se, it was estimated that around 4 million people are going to be dying due to antimicrobial resistance. And this was the initial thoughts. After the publishing of the study, there were lots of studies. One of them is a famous one, which was published in PLOS ONE, asking, is 10 million as a number, is it overestimated? Is it underestimated? Do you think that really 10 million people are going to be dying out of AMR by 2050? And there was lots of talks about this. That was then the study that was published in the Lancet this year in February 2022, which is considered the first real study doing the calculations and the modeling and everything to anticipate and say what is our current situation. So this study, it was modeled, it was published again in the Lancet, according to the death in 2019. So this study didn't even take in consideration the problem of the COVID, which is again another huge problem that have estimated, of course, in the increasing of the AMR burden, but they didn't even put this in consideration. So they only did calculate the study of the death in 2019. They did say that there was direct association of death, around 1.27 million deaths already happening in 2019, which is directly associated to AMR. And they were saying that there are around 5 million deaths, which is not directly associated with AMR, but it is due to AMR. And this makes AMR the third leading cause of mortality currently worldwide. This is really shocking. And if you can have a look at this, the Sub-Saharan areas is the highest where the death attributable to antimicrobial resistance has occurred. And this is really very alarming, and this is really should be dealt with very cautiously in the upcoming years. So this is another interesting thing that actually recently published. It was published in the past couple of days, which is I believe there is a background noise.
Sorry for that, Dr. Yara.
No. So this is a recently published study about its mapping antimicrobial resistance and antimicrobial partnership. It was focusing about this. The map reviewed around 8,000 AMR records from 2016 to 2019, working on Africa specifically. So Africa has the highest, and this is what was published about this, that it has the highest mortality rate from AMR infections in the world, with around 27.3 deaths per 100,000 attributable to AMR. And this is really, again, very, very alarming. So the Lancet study, along with this mapping, is really very alarming to what's currently going on. Again, I would highly suggest that you can go through this. This is published by the IDSA, and the IDSA is the Infectious Disease Society of America. It has published this on 2018. It's called Faces of Antimicrobial Resistance. So basically, people are always, let's say this, they're always understanding the burden per se per cancer. So people they have the sympathy for people suffering per se from cancer. They understand how cancer can be deadly. But the aim of publishing this report was to get the common sense and understanding of people in the community about the danger of AMR. So in this report, you will find the stories of real people losing their lives because of AMR and antimicrobial resistance, just antimicrobial resistance, where they were left to die because simply there were no antimicrobials left to treat them and left to help them out, just like this. So maybe, and I face this a lot in my practice, we have this patient, he goes in for, per se, a road traffic accident. He goes in because he was having this whatever kind of procedure, and he stays in the hospital. He gets the nosocomial infection, antimicrobial resistance, and then the patient simply dies. So he just comes in for an elective surgery and he doesn't leave the hospital. This is really very scary, very alarming, and I really face this in my practice a lot and a lot. And the very alarming thing that this is not only in the hospital, we're facing even this in the community. So per se, when we're doing a rectal swab for patients coming from other hospitals or even coming from the community, we find this CRE, which is carbapenem-resistant Enterobacterialis and extended spectrum beta-lactamases carriers in the rectal swabs. So without going into these medical details of the whole thing, because again, this is a general presentation, but again, what I wanted to just flag here, that even the community, people in the community now are coming with resistance patterns, and this is very scary. Working in the NICUs and the PICU, we have high burden of carbapenem, again, resistance or gram-negative bacteria resistant infections in the pediatric population. Again, very scary and very alarming. Mothers of children who do take antimicrobials, their children, their offspring, there's vertical transmissions of resistance, and then babies born. We find people, babies born with sepsis, and we having again patterns. So this is really very alarming. So again, this was published with the World Bank, but again, this is some old data because again, this was before the publishing of the Lancet study. And as you can find here, the estimate again by the World Bank was that AMR could cost around 100 trillion USD between 2050. And this is really, again, very, very, very alarming because this was even according to the old data. So this is adapted for one of the studies published in 2014. I'm just flagging this out to say that resistant organism, it's not only about the mortality and morbidity and length of stay in the hospital, but it's also about the range of excess costs. So as you can see here, if we're talking about the methicillin resistant Staph aureus per se, and this is a gram-positive bacterial infection. So for the resistant organisms, they are like 100 times even excess cost than just dealing with a methicillin susceptible one, the one that you can simply treat with a first generation cephalosporin like the cefazolin or even a penicillin. So this costs 695 USDs, and the other one costs 29,000. So it's a lot. We have 21,000 excess cost just for this. And then another gram-positive cocci, which is the Enterococcus, which you can find a lot in the urine. You can find it can cause a bloodstream infections as well. Not very common, but yet can do. When it's vancomycin resistant and when it's susceptible, vancomycin susceptible, you're talking about around 40 to 40,000. And this is a lot. And again, lots and lots of costs and burden, specifically when we're talking in low middle income countries. So this is really very important to be taken in consideration. So I just wanted to talk about the microorganisms with a threat level of serious. This is the latest revised report by the CDC. It's in December, sorry, 2019. This is a report where the CDC classifies the microorganisms according to their threat level. So why I'm putting this, why I'm adding this. So the CDC, the threat level serious are all microorganisms that I personally deal with every day in my practice. So again, very, very, very alarming. And this is the WHO one. So this is the classification of the CDC, and this is the classification of the WHO. So we have this again classification of critical microorganisms, which is something gram-negative like the Acinetobacter baumannii non-fermenters, and the Pseudomonas as non-fermenters, Pseudomonas aeruginosa. And we also have the Enterobacterales as a critical pathogens. And here in Egypt, we have a huge problem specifically with the Enterobacteriaceae, the Klebsiella, to be very specific. And then we have the high, which is the Enterococcus, as I was talking about earlier, which is a gram-positive, and the Staphylococcus, which is again a gram-positive. And then the medium, which is the Strep pneumoniae, and this is not very commonly found in Egypt. And supposedly the Strep pneumoniae, again, it's a normal colonizer and a normal carrier. It's a nasal carrier, but it's not very common. We don't find it common here in Egypt. So again, we really need to be securing the future and working about this issue. So AMR, it's not the human problem only. It's not the plant sector, it's not the environment, it's all of them. And that's why now we have the terminology of the quadripartite, which entails working with the human sector, entails working with the World Health Organization for Animals, which is the WOA, entails working with the environment, and of course with the FAO or the plant section. So it's a One Health issue, and it's definitely related and correlated with the Sustainable Development Goals. And there was a report published last year about the relation of AMR with the Sustainable Development Goals. So definitely it will have a problem on accelerating the progress in the countries, on securing the future. Definitely will impact more than one of the Sustainable Development Goals. So I personally, I consider this slide is very, very important. It sums up all what I was trying to say, that it's not one section only problem. So as you can see here, the misuse or the abuse of the antibiotics, it definitely leads to outbreak of antibiotic resistance in the animal section, terrestrial and aquatic part, and definitely impacts the human part of it. And then there's a direct conflict between the animal part and the human part. It can be done through inappropriate cooking, processing of the food, and then this goes back again to the human. And then the feces, the human feces and fertilizers, they go back here in the plant, and the human feces as well, and the medical supplies, they are discarded. And all of the wastes coming from the pharmaceutical companies and so on. This is again in the sewage and all of this. So it's a connection. It's an interconnection between the human side, the animal, the plants, and the environment as well. And of course, this leads to outbreak of antibiotic resistance and nosocomial transmission, which then goes back to the community. And this is a vicious circle that will be going round and round and round endlessly. So this really requires a comprehensive multi-sectoral response among all the parties if we really want to be doing and if we want to be working on this part. So this is really very important. So again, the human part, we need to be working on the inappropriate use of antimicrobials, the poor access to quality and affordable medicine. This is really very important. So we have the counterfeited antibiotics, and this is a huge issue. We have a good quality antibiotics, so you can be given. Let me tell you a story that I've been hearing, that in some hospitals, because they are not sure of the quality of the antibiotic, they give like 4 times the dose because they are not sure about the quality of antibiotics. So this is complete destruction of the antibiotic itself. You are not aware of the level of the drug that you're giving. You're not aware of the efficiency and the effectiveness, and this is really not a good thing at all. And then the affordability, which is again a very important thing to tackle. So sometimes people in the hospital, they do need reserve or last line antibiotics, and sometimes this is not affordable, and you start giving the first lines in spite that the patient needs the last line antibiotic, and then the patient dies with even more resistance because he didn't receive the appropriate antibiotic, and so on and so forth, and you're giving just unnecessary antibiotic and creating more resistant issue as well. Working as well on the vaccination part, which is really, again, very important, and flagging it for the second time. This is really important, and it's part of the plan with dealing with and tackling the AMR problem. And of course, the importance of the diagnostics. So I can see here that there are lots of people, they are working in the labs already. So diagnostics are very important. That's why we have something called the diagnostic stewardship, which entails working with, again, good quality data, good lab proficiency testing for the specimens, and so on, to make sure that we have good culture, reliable culture that physicians can rely on in order to give the appropriate antibiotics or antimicrobial regimen for the patient. And then we have the water, sanitation, and hygiene, which is the wash. Of course, the lack of access to clean water, as this is, I know, seems very basic, but believe me, it helps a lot in this issue. So the lack of access to clean water, sanitation, and hygiene, of course, it, again, back to the mode of transmission that we've been discussing, we're not breaking the chain here. We're not breaking the cycle of the infection. And of course, the environment, again, the discharge of waste, including the antimicrobial residues. And this is a whole issue. And that's why environment is now a very important part and a very important aspect that's joining the quadripartite I've mentioned earlier. So let me tell you something, that sometimes the concentration of the antibiotics in the water is even 10 times higher than the blood concentration in the human being. And this is really very scary. We drink this water, we bathe in this water. So again, the environment joining is really, I believe, very important. And then the terrestrial and aquatic animals, the misuse and overuse of antimicrobials, again, as growth promoting factor, giving the colistin, the colomycin, which is the last resort of antibiotics in human beings, just giving it and feeding it to animals with unjustifiable quantities, and even not knowing how many vials you're breaking and giving to the animals. So this is crazy. Again, the food and the transmission of the resistant pathogens back again to the food. And the plants, they spray streptomycin on some plants, and this is crazy, and this is again creating more and more vicious problem. So the factors contributing to antimicrobial resistance, there are many, but of course, one of the biggest drivers, as you can see in this study published in 2016, is the misuse or overuse in the human side and in the animal side as well. So unfortunately, the antibiotics, the ones that we're misusing, the ones that we are abusing, and the one that is really causing a major issue in antimicrobial resistance, is again the burning and the blocking and the essential building block for all the practices in medicine. So without antibiotics, how are we going to be treating patients in the intensive care? Patients receiving chemotherapy, the pediatrics, people undergoing organ transplantations. How can we do this without antibiotics? It's the first thing that you should be giving it. This is the surviving sepsis campaign. It's in the 1 hour bundle that you should give to the patient suffering from sepsis and septic shock. So antibiotic, it's the cornerstone. It's where everything in modern medicine is built on. So if we lose antibiotics, we lose modern medicine practices. So again, this is a study which was published in 2014. This is a meta-analysis, a systematic review and meta-analysis, which is directly relating and correlating the effects of antibiotic consumption on antimicrobial resistance, and clearly stating that antibiotic consumption is associated with development of antibiotic resistance. And again, it's the main driver for having an AMR or antimicrobial resistance. So we're not suffering only from the COVID pandemic, but we're actually suffering from the global epidemic of irrational use of antibiotics or medicines, and of course, antibiotics, irrational prescribing, just pathological prescribing. This is really, again, crazy. It's overprescribing, is using the newer expensive drugs. So again, sharing one of the experiences here in Egypt, we have this molecule, which is called the Landsat. This covers a gram-positive bacterial infection. And since it is an IV and oral form, it has an IV and oral formulations as well, physicians, they find it very easy to prescribe it to. So we give they write Landsat for everybody. Dental procedure, go get a Landsat. Rhinoplasty, go get a Landsat. So they're prescribing Landsat like crazy. And it's not even covered, over-covering organisms that they don't need even to be covered. So as you can see here, this is published in the CDDEP, now called the One Health Trust, which is the Center Disease Dynamics, Economics and Policy. This was published in the States of the Worst Antibiotic 2021. As you can see here, the high-income countries versus the low-middle-income countries, you can see that the drug-resistant index is very high in the low-middle-income country rather than the high-income country. So the high-income country, they're not even having this huge of a problem like though in the low and middle income countries, yet they are the ones doing the effort, they are the ones doing the research, they are the ones doing the surveillance, they are the ones doing the actions. In low middle income countries, they need to pace up with them, they need to join them, they need to be starting working on this on so many levels as we've been speaking. So again, this is a very newly published, it's published, I believe, in a week or something, which is the African Society for Laboratory Medicines, which is mapping antimicrobial resistance and antimicrobial use. As you can see here, this is the DRI, and the DRI, again, this is the drug resistant index, and it correlates the effects of antibiotic and how well it's doing regarding the resistance issue. And this one is done in Africa, and supposedly the cutoff point is 25%. So if you are under 25%, then you're doing a great job. If you're above 25%, then you're really having a problem. And as you can see here in Africa, in 12 African countries, all are even above 50%, which is twice the normal, because again, the benchmark is 25, and all countries, they scored twice the benchmark. Again, this is very scary and very alarming. Not even this, when again this report was published in 2021 in the CDDEP, they were studying the antimicrobial utilization in the Francophone in West Africa. As you can find here, since 2000 to 2015, it's shooting, it's rising, it's shooting. We're talking about global antibiotic consumption increasing by 65% globally, talking globally, between 2000 and 2016. And the rate of antibiotic consumption, again, expressed by something called the DDDs. We don't want to go in details, but at least the DDDs, this represents the antibiotic consumption. It has increased by 39%. This is, again, crazy. And specifically speaking about the Francophone West African countries, again, rising from 5,000 to 10,000. So we're talking about twice the number in the last 15 years. So this is only part of the problem. So it's not that we are heavily consuming antimicrobials like crazy. It's not that we're having very high DRI or drug resistant index. The problem is that we are saying goodbye to the golden age of antimicrobials. So we're having a huge problem with pharmaceutical companies. They are not actually producing antibiotics because they say, why do we produce antibiotics? Because they're going to have resistance. We're not going to sell them, and they're going to stay on the shelf. So why do we spare the money and the time and everything? So the golden age of antimicrobials actually was since 1950 and then 1960. And the funny thing is that the last agent that was the new molecule, which was the Landsat, this is the last thing that we know. So this was like 30 years ago. And now we don't have any novel molecules of antimicrobials. So we have combinations, we have beta-lactam, beta-lactamase inhibitors, but we don't have new and novel molecules of antimicrobials. So again, the antibiotics R&D, it has not responded to the urgent need of new antibiotics. Again, there's a lack of investment. As you can see here, number of deaths is shooting and number of new antibiotics is actually declining. So we're having a problem, a failure in the clinical and preclinical antibiotic pipelines. We're having a problem with the regulatory, with the development process. It's a failing market. As you can see here, declining. It's very clear that the number of new antibiotics developed and approved has steadily decreased in the past 3 decades, again, leaving a very few options. So we're consuming antibiotics like crazy. And the other problem is we don't even have enough antibiotics that are being produced in the pipeline. So the catastrophic period was actually between 2010 and 2012. Later on in 2014, we have been like new antibiotic agents that are currently under development. But again, this is all under development, and you can have more data about this in and this is the 2021 antibacterial agent in clinical and preclinical development. It was actually published in May 2022, so a couple of months ago. They are saying that the current antimicrobial pipeline, it does have 77 antibiotics. People are slightly starting to realize that we're having a problem and we need to be working on, but not on the very positive side. That there's only one compound, which is the cytidecol, only one authorized compound, which is intended for the use against the WHO critical pathogens that I've discussed with you earlier, which is for the carbapenem-resistant Acinetobacter baumannii and the carbapenem-resistant Pseudomonas aeruginosa. So again, yeah, we have new agents, but only one of them, which is actually really going to be facing the critical lists of the WHO. So why we're having a problem? Why are we having a problem with the appropriate use of antimicrobials? Why is there a problem about this? So some is actually related to the patient factors and others are related to the physician factors. So we have a consumer demands. Here in Egypt, per se, the physician who does not prescribe antibiotic, the patient who says that he's a stupid physician. He's not a good one. I'm not going to go back to him again. So we have a problem with the consumer demand. They consider it part of the standard of care. Okay. So this is an issue. Community people are having misconceptions about what antimicrobials do. So you have a viral infection, go take an antibiotic. They don't understand. Any fever, they believe does require antibiotic. It has a healing power. Why do I go as an economic factor? Why do I go and spend like a bunch of USDs for going to a physician and missing work and so on? No. I would just take an antibiotic and then I'll feel good. I'll be perfect. I can go to work. I won't be missing work. I won't be paying for the physician. I'll just go to the pharmacist. He can prescribe whatever antibiotic and things will be good. So this is an issue. And then we're having issues, to be honest, also with the providers themselves. So there are like really tons of reasons. So inadequate knowledge. Per se, there's a lack of infectious disease physicians in the low middle income countries, per se. So not all the physicians have this basic knowledge about how to properly prescribe antimicrobials, the basic principles and practices on prescribing antimicrobials. Sometimes it's hierarchical issues. So when you go with the junior physician, he's like, oh, no, the consultant, he's the one that he ordered me to be writing this antibiotic for the patient. If you want to change it, don't go talk to me, just go talk with the consultant and see if you can change with him. So we're really having this huge problem. And this is not only the factors, there are other factors that are really contributing into this, like the marketing influences, the pharmaceutical companies, the untrained source of advice, the incentives, issues, of course, other regulatory issues. So per se, here in Egypt, yes, we do have a law that say that bans prescribing, dispensing antimicrobials over the counter, but it's not enforced. So we have the law, but it's not enforced. So again, this is another problem. So what can we do about this? So we stated the problem, we discussed the problem, we discussed how far is the problem, we discussed the global burden of the problem. But then what should we be doing about this? How we can resolve this issue? So in May 2015, the 68th World Health Assembly, they adopted something called the Global Action on Antimicrobial Resistance. There are 148 countries. They do have finalized their national action plans. 38 countries are in the process of developing their own apps. If you want to know more, I have left here the link, which has all the library of the AMR National Action Plans. If you can go to this link, you will find all the published national action plans for the countries. And people are doing really amazing job, and we are all learning, and it's in the preliminary phase, and we're all learning, and we're all learning from each others and learning according to the context of our own country. So yes, the global action plan, I believe in my own point, it's very ambitious, it's great, it's ambitious, it's dreamy, it's everything, but the implementation part, it's the whole bits of it, how to adapt it in your own context and work on it in your own context. So the global action plan basically has 5 pillars, 5 main objectives that it works on, which is improving the awareness, strengthening the knowledge through the surveillance and the importance of surveillance and having what we call integrated surveillance, reducing the incidence of infection, we working with the IPC, optimizing the use of antimicrobials, and ensuring sustainable investment in having the funding and the research and the whole bits of it. So again, you have the bits of the governance. Again, AMR, it's a major problem. It's a problem for all of us. It's not only the human, it's not only the animal, it's not only the environment. So this entails the importance of effective multi-sectoral governance across and within sectors. This is very important. Having proper monitoring and evaluation parameters, having clear and simple indicators, and not very ambitious things, just very simple, very low maintenance things that we can keep up with. The importance of linking this with health systems and strengthening this under the universal health coverage, this is again very important. Again, the bits of the awareness, which is raising the awareness, enhancing the education, in-service trainings for the health officers. All of this is really important. Community engagement, again, very, very, very important for the community to understand this behavior change, which I believe is, again, very, very, very important and takes time, and it does not happen all of a sudden. And one of the really, really very successful experiences that we can all learn from is the Thailand and the Thai experience, where they really did a great job, and it took them several years to reach what they have reached now, that they accomplished almost 90% of all the indicators that they have set for themselves. Again, knowledge, having an AMR surveillance system, surveillance for the antimicrobial consumption, the antimicrobial utilization, laboratory capacity, diagnostics, and all of this. For reducing the incidence of infection, again, strengthening the infection prevention and control, hand hygiene, sanitation, immunization and vaccination, as I was talking earlier, doing healthcare associated infection surveillance and understanding the baseline and how we are going in each country. And of course, again, optimizing the use of antimicrobials. So doing antimicrobial stewardship, regulation on antimicrobial use, and maybe later on, if there's another session or so, we can discuss a bit more of antimicrobial stewardship and the importance of regulating on the antimicrobial use, adopting the aware classification. We can maybe discuss a little bit more on this, and having, of course, access to affordable antimicrobials. All of this is the basic plan. Again, each country can tailor according to its own context, according to its own capabilities, the resources, the capacities, everything. Each country should have an ownership of its own national action plan, and it should tailor it according to their own problems, their own, again, available resources and funding and all of this. So you don't have to be working in all of them. You can set priorities and work it one pace at a time. So this really concludes what I was trying to deliver for today. I hope I managed to just, again, touch upon different concepts related to infectious diseases and an AMR. It was really, again, a huge pleasure, and thank you so much for this.
Wow. Thank you so much, Dr. Yara. I know we are 8 minutes past time. I'd like to ask if you have a few minutes for some questions. we could have the rest sent to you for response later.
Yeah, sure.
Okay, good. And Anita, please unmute and ask your question. Anita? I don't know if it's just me, probably Dr. Yara or Daniel could confirm if you can hear Anita.
I am so sorry. I really can't hear. I really can't hear. I'm very sorry.
Okay, so as Anita did, yes, please go ahead.
And hello, Anastasia. I think Anita was using some earphones or something. Maybe Anita, you can remove the earphones. Maybe they're the ones which are limiting the sound. We can see that you are conversing. Thank you.
Okay, thank you. I'm done with removing them. Like I was asking if she can clarify for me, like the phase that those infectious agents take along to end up someone reporting that I'm having a disease, like the phase of infectious disease for someone to report that she's having the disease, what's the phase that the infectious agents take along to end up causing someone a disease? Thank you.
Yeah. So if I did understand your question correctly, so you're maybe talking about the incubation period, which is the time when the infection occurs to the onset of signs and symptoms or the first positive test. And then, of course, you have the case definition of how you can say that this person has an infection. But what I believe what you're trying to maybe ask on, again, it's called the incubation period, and it's again the time from when the infection occurs and then till having the sign of infection. So, yeah, if we can, and I don't know if you can hear me, but yeah, if we can have another like question or something.
Thank you so much. Like from the pre-class materials you have been trying to read, they were just like taking those phases, like they were explaining them as 6 phases, like incubation. The other one, when someone is having signs which are quite.
Yes, you're talking about the difference between decolonization and subclinical and latent, maybe? This is what you're referring to?
Yes.
So sometimes this is very important, that sometimes the infection, it doesn't necessarily have to be manifested as signs and symptoms. So sometimes you have a colonization. So you have these like microorganisms, they are living on your body, but they are not causing any infection. So again, like the staph epidermidis living on your skin per se. And then sometimes you have this subclinical where you get infected, but you don't have any appearing signs and symptoms. And sometimes it's a latent infection, like the latent TB per se, where the organism, it's there, you have it, but it remains inactive in the body. It's there, it will last, okay, but it is inactive. And sometimes you have the systemic signs and symptoms of infection, like having what's per se the septic shock thing. I hope I've managed to answer your question.
Oh, thank you. It's clear. I got it. Thank you.
Yeah, great. Yeah. Thank you.
Okay, thank you for that. So next we'll have Hakizimana. Please unmute and ask your question.
Hello, can you hear me?
Yes, please.
Okay, thank you. My question goes like this. As we know, pharmacists are more accessible healthcare professionals to the community.
Yes.
So I was asking, what did you suggest as the contribution of the community pharmacist can do just to to minimize or to fight against the antimicrobial resistance? Because as you have seen, they're just giving the antibiotics to the patients always and always, and people in the society are able
Yes.
to just get antibiotics in easy way. So can you please suggest the contribution of community pharmacists to fight against the antimicrobial resistance? Thanks.
Thank you so much for your question. This is really very, very proactive and very, very good question. So basically, yes, I agree 100% that the community pharmacists do have a great burden on this issue. But they can definitely help in the awareness bits of the thing. They can really play a role in the awareness of the community about this. Another thing is that there are some resources about using antibiotics in primary care and communities and so on, like for simple infections. There's the WHO book. It's going to be launched at the end of this year. It's the antibiotic guidebook. It's very simple. It's mainly for primary care and again, like the community infections, let me say it in a simple way. So definitely you can use this as a reference, a resource to help you regarding the usage of antimicrobials in the community. This would really help a lot. And again, it's going to be, they are also planning to do it as in an app as well. So maybe that would be really helpful to, again, have it on your mobile and so on. It's going to be launched at the end of this year. So I really hope this can help.
Okay, thank you so much.
Yeah, you're welcome.
Okay, next we'll have Adrian. Please unmute and ask your question. Hello, Adrian. Okay. Adrian, we can't seem to hear you. Someone could confirm it could be my end.
Yes,
We all
Senator,
can't
you
hear
can
you.
hear Adrian.
Okay, maybe Adrian, you could type in the chat box. I don't know what's happening. I can see you're unmuted here, but we can't hear you. Jennifer, please unmute and ask your question. We'll go back to Adrian afterwards. Yes.
Thank you. Good evening, everyone. I want to ask, why is it that the high-income countries have a low burden of antimicrobial resistance, while the Sub-Saharan Africa has a high burden of AMR?
Yes, thank you for this question. This is really, again, a very, very important actually question. So basically, again, as I was just saying, they are the people taking, taking the initiatives. So they have, if you can see, they have less consumption for antimicrobials. They have better IPC practices. They do their surveillance. They have like baseline data and they track it down. And if they have a problem regarding one thing or another, they start working on it. So this is, again, this is really very important. So that's why we need to be doing more work. This will definitely differ between us in low middle income countries versus high income countries. But again, at least we can start. So I'm not saying that we should adapt per se antimicrobial stewardship. We don't need to be doing the exact thing that they are doing, because they have their own problem. They have less burden of resistance. They have their own issues. But again, at least doing interventions and intervening with WASH, good IPC practices, good regulations for over-the-counter of antibiotics, good practices regarding using antimicrobials in the hospitals, and so on. I hope I've managed to answer your questions, and I really would recommend that you can read more about this again in the CDDEP, the World's Antibiotic Status, which is published in 2021. It really goes into different details about the mapping of the resistance and the reasons about this, and even access to antibiotic. This is also another issue, that they have good access to quality antimicrobials, and this is also another issue. Thank you, and over to you.
Thank you, Dr. Yara. If I could confirm. Okay, Adrian, I'm going to try one more time. Okay. I see Adrian's hand has gone down. Probably for your question in the chat room. So on to Iradat. Please unmute and ask your question.
Okay, thank you. Am I audible, please?
Yes, you are. I can hear you clearly.
Okay, thank you. My question is concerning the factors that actually brings about AMR. She mentioned food and feed. So I want to know how food and feed actually brings about AMR and how it can be prevented. So it can prevent the AMR spread or AMR disease. I want to know how food is related to it. Thank you.
Okay. Thank you again for the question. So there, again, globally, there have been like tons of initiatives doing this, like per se, even really, really big franchises, even like McDonald's and KFC, they ditched antibiotics in even the poultry and so on. China itself did have, after the COVID, they declared that they are not going to be using colistin for animals any way or another. So it was clear, again, that's why it's important to have very clear regulations, to have very good governance and multi-sectoral collaboration, what's called by the One Health. So this happens when people sit together, when people take decisions, and again, this is very important. So this is not a one man show. It has to be, again, aligned, and it has to be embedded in the system itself of the country, and it has to be very clear decisions upon this issue. Thank you, and over to you.
Okay, thank you very much, Dr. Yara. You have very many people in the group saying thank you, and very many comments. Hands just keep going up. Thank you so much for your presentation. So next we shall have Benny. Benny, please.
Yes, thank you. Thank you so much. Can you hear me?
Yeah, I can hear you very clearly.
Yes, I have. Okay, yes. Yes, I have a question on issues of AMR data systems. Well, we have seen that from Sub-Saharan, the data are very, I don't think how effective are they, because that we have proper surveillance systems, we have proper data systems from even the grassroots areas. How are these data acquired? And also, how are the data of the knowledge of people having on the statuses of AMR knowledge to this issue as a whole?
Yes, thank you for the question.
So I was asking that
Yes. So thank you so much for your question. So basically, again, so the data regarding the Sub-Saharan, we have like two references. One, which is the Landsat study. Again, of course, these are all models. These are the highly brainy people who did this. I believe this is an enormous. This is the only really comprehensive study about the global AMR burden, the one that was published again in 2022. And these are really very great statisticians and models who did put this data together. Of course, we still have more data that can be presented, and we need more surveillance in the Sub-Saharan area, and we need more data about this. But again, the more interesting, and I can share this maybe with Daniel after the presentation, which is the report I was mentioning, which is called the crisis within the crisis, which is the mapping one in the African region. It has many really interesting facts similar to what you're saying. So per se, that 80% of the drug consumption are represented by excess drugs. which actually aligns with the WHO recommendation, and it looks like a good thing. So yes, great, 80% of the African antimicrobials are within access, not reserve, and this is great, and it looks great. But the real truth lies behind this, which is is this the real thing? Are we really complying, or the issue is that we have lack to access to certain antibiotics and erratic use of antibiotics that are available? So that's why it looks good, but the reason behind this is that we don't have access to real antibiotics that is really needed, and so on. So I would believe that, again, I always believe that working with setting your targets, knowing what you need to be working on, having proper data that can guide you to where you can move. This, again, could be really very helpful and could guide you to where you want to start your work. And that's why having a national action plan, I always say it's very easy to write a plan. This is very easy. It's always the implementation part which is hard. Again, deciding on your priorities, how you want to be working on, what are your finances, what are your available data that you can help you and, again, guide you on how you want to be working. So I hope I have managed to answer your question. Thank you.
Thank you so much, Dr. Yara. I know we have gone beyond time. It's 26 minutes beyond time. I don't know if you have some more time you could spare, or we could ask the participants to share these questions in the chat room and we could have them sent to you.
Yeah, maybe I'm really very sorry, but yes, of course, I have no problem. You can definitely send the questions via email, and I will share with Daniel after we are done also the report I was talking about. And again, I really need to say this. I mean, all of the people here, great number of people attending, very enthusiasts, and I'm really very happy with your engagement. This really makes me very happy, because I always say, students, you are the doers, you are the future, you are the people working on this. And there are different specialities that I can see here. So it's really great. And again, having you and your support on this, each one in his own country and each one in his own field of work and field of study, is really very important. So actually, I'm the one who's really very thankful for your presence and for your engagement on this.
Thank you so much, Dr. Yara, for spending all this time with us and sharing your knowledge with us as well. So for everyone else who hasn't had the chance to ask a question, and for those questions that were already in the chat room that started coming in during the session, please don't worry, I'm going to collect them and send them, and then you'll get your feedback. So yes, thank you once again, everyone, for attending. Thank you, Dr. Yara. Probably over to you, Daniel.
Yeah, thank you so much, Anastasia, for the session and also for moderating. Thank you, everyone, for your insightful contributions too during the session. We do appreciate. And as usual, Dr. Yara, perfect at always what you do. Thank you so much. That preparation was very elaborate and really a very good kickstart as we start the program. It's great to have you. As you've seen, we have multidisciplinary approach, and at least this time we have students from different professions and different backgrounds, and the essence is to see how we can also nurture each one of us and see how we can contribute based on our own expertise and also what we learn and the collaborative engagement, what we come up with. So thank you so much. I don't want really to dilute what you've said, but I'm really thankful for that elaborate presentation. I hope to our participants, you've learned something. The attendance was quite great, almost 100. And I will share the presentation. And if Dr. Yara allows us, we will also upload the recording for the session. Maybe we can have it publicly, maybe via YouTube, and so that other people are also able to have a feel of and also really learn from this great presentation, which was a very great overview and a summary of the burden of AMR, right from infectious diseases all the way to trickling down to governance issues and the action points that we can take. So without taking any other time, I wish us a wonderful evening and maybe a great time ahead. And we hope to have you, Dr. Yara, back as we continue at another time. Thank you so much.
Thank you so much.
And-
Always a pleasure. And thank you. Thank you all for engaging. Thank you so much and have a very pleasant evening. Thank you.
Okay, evening to us all.
Thank you so much, Dr. Yara.
Evening to us all.
Thank you.